She holds a master's degree in public administration from the Harvard Kennedy School, a master's in business administration from the Chinese University of Hong Kong, and a first-class honors degree from the University of Queensland. She is a Salzburg Global Fellow and was a Global Australian of the Year in 2021. We are honored to present this award, the 2024 Rice 360 Innovation and Leadership Award, to Leith Greenslade today. We award this accolade to those who best exemplify our Institute's dedication to innovation and global health. As a true visionary in expanding global health innovation and equity around the world, Leith embodies the qualities we want to see in our students as future global health innovators. She is one of my personal heroes. Leith, thank you for your leadership and impact toward creating a more just world. Join me in welcoming Leith and for her keynote address.
So thank you, Maria, and the entire Rice 360 team for the honor of being here today and for the honor of receiving that award. It means a great deal. What a precious garden, Maria, you and Rebecca have tended all these years, and today we get to see some of the flowers bloom. So this is my first time in Texas, so it seems a little strange to be welcoming people, but I do want to welcome everyone. We have 24 teams, as Maria said, 15 in the room, I think 9 virtually. So hello, everyone. And this is open to all. So we have a global audience watching us today. So welcome, everyone. I want to spend the time we have together today to tell a story about the global health world that you are inheriting as students at the beginning of your careers, which is really at a crossroads. And I want to imagine ways you might be the ones to make sure it changes for the better. I chose the title Brave New World to be provocative. It echoes the Aldous Huxley book, which many of you have read. The book was published in 1932 and describes a future society that revolves around technology, which has remedied all ills apparently, but the place is a kind of living hell. The subtitle is How Biomedical Engineers Can Shape a Brighter Future. So no pressure, but you are the heroes of this story. It's up to you to deliver a better future, at least for global health, by doing things differently with technology and the engineering power you each possess. So let's go on a journey. I want to take you back. It's the early 2000s, and global health, what we call global health, even that term now is contested, we'll talk about that later, is being built. In 2000, we got our first set of global goals, really a phenomenal achievement. They were called the Millennium Development Goals. There were only 8 of them. 3 of them pertain to health, MDGs 4, 5, and 6. MDG 4 looked at child mortality, 5, maternal mortality, and MDG 6 singled out 2 infectious diseases, HIV, AIDS, and malaria, and tuberculosis was implied in MDG 6. At the same time, 5 new global health institutions arrive on the scene. What started this off? Bill Gates and the enormous fortune he made at Microsoft, turning that into the Bill and Melinda Gates Foundation. And after that, we had some hugely powerful global health institutions founded largely with Gates money, but not only. Gavi, the Vaccine Alliance in 2000, followed by the Global Fund in 2002, that focused on HIV, AIDS, TB, and malaria. There was a Nutrition Alliance and Unitate in 2006, which largely followed the Global Fund's mandate. Under the line there are 2 incredibly important initiatives. They weren't global, they came from the US. In 2003, PEPFAR, you've probably all heard of PEPFAR, the President's Emergency Plan for AIDS Relief, and PMI, 2 years later, the President's Malaria Initiative. Who was the president? President George W. Bush. And politics aside, if there's one political leader in the world who's more responsible for building global health in that period, it's actually George W. Bush. And those initiatives still have bipartisan support in the US government, which is no mean feat. So what happened to financing? Between 2000 and 2010, you can follow the red arrow, there was an enormous influx of money into global health. Yes, the Gates Foundation, but not only. I can actually give you some of the amounts of money. So between 2000 and 2010, global health spending went from US 12 billion to almost 40 billion. The US was about 10 billion of that. So we look back now and we call this the golden age of global health financing. You can see it flattened off once we got beyond 2010. And the two bars on the far right, that's COVID money. And we'll get to that shortly. Where did all this money go? It largely went to 3 infectious diseases: HIV, AIDS, TB, and malaria. That's the green and the blue bars at the bottom. There were other things in there, but those 3 diseases certainly captured an outsized amount of that money. So by 2015, no surprise, MDG 6, that was the MDG focused on HIV, AIDS, TB, and malaria, is achieved. And global health really proved its value. These 3 infections which were raging, they had been turned around. Look at the bend in these curves. Look at HIV AIDS. This is deaths per 100,000 between 2000 and 2015, the life of the MDGs. Think of the effort it took to bend that curve. TB and malaria also enjoyed declines, not as much as AIDS, but significant declines. And these were periods when population growth was really rapid in many of the parts of the world suffering from these illnesses. But what about MDGs 4 and 5? Not achieved. Progress, yes, but not enough to achieve the goals. So child deaths came down, the maternal mortality ratio came down, contraception access went up, but none of those goals were actually achieved. But global health didn't give up. Global health came back in 2015 with an even more ambitious set of global goals, and you all know those, the SDGs. There are 17 of them. We see these are the health goals, 9 health goals, up from 3. There's a lot in there that's familiar to you. You see maternal mortality, you see child, but look at neonatal. Neonatal mortality is pulled out in recognition of the massive burden of death that occurs in the first month of life. AIDS is there, malaria is there, TB is named. And look at 3.4. We just start to see non-communicable diseases come into the set of global goals. In the MDG era, we really didn't talk about them. And there's other very important issues there: substance abuse, road accident deaths, etc. So everyone's set to work on trying to achieve those goals by 2030. 2030 was the deadline. But even by 2019, there are signs that something is changing in the world. The planet is certainly getting hotter, and this is having major implications for health that we're starting to see. We're starting to see infectious disease outbreaks more rapidly and with a shorter time span than before. I've listed Ebola, Zika, yellow fever. We're in the middle right now of measles outbreaks, including in high-income countries. Cholera, many parts of the world are struggling with cholera right now. I should have had Mpox on this chart just today in the media. There's more Mpox concerns in Africa. So we're starting to see these very alarming infectious disease outbreaks that scientists are telling us are heat-related. But at the same time, on the chronic disease side, we're seeing a rapid rise in non-communicable disease deaths. So we have to hold these two things in our head: the risk of infectious disease outbreaks rising and this massive increase in chronic conditions. These are the 3 buckets that the global burden of disease divides human death into: communicable, non-communicable, and injuries. And you can see communicable falling. We would expect that. We've been working on that. Non-communicable rising, and injuries are flat. And the NCD shift, the non-communicable disease rise, is not something that's just happening in high-income countries. It's happening everywhere. While we're busy working on infectious diseases in Africa and other parts of the world, the non-communicable diseases are creeping up and up and up. So too in South Asia, Latin America, and the Middle East. This is a global phenomenon. And then the unimaginable happens in 2020. While we're grappling with these conflicting challenges, the world is hit with a global pandemic of respiratory infection, killing between 7 and 30 million people in less than 3 years. To give you a point of comparison, at the height of the HIV/AIDS pandemic in 2003, 4, and 5, an equivalent 3-year period, 5.4 million people died. And COVID killed at least 7, that's the official World Health Organization number, But recent studies have been done estimating excess COVID deaths, and it's as high as 30 million. Because many COVID deaths, as you all know, were not recorded. They were hidden deaths. People didn't even make it to a health facility, or they died, the deaths were misclassified. They were actually COVID, but they were classified as something else. So this in our lifetime is the largest pandemic I think we've ever had to face, but it may not be certainly the largest in your lifetimes. No region was spared, although the official count put 75% of COVID deaths in the Americas and Europe. It's probably not quite right because so many of the hidden COVID deaths were concentrated in other regions. But this was truly a global pandemic. I want to pause a minute and just remember the people who died during COVID and the many more who suffered and are left with the trauma of that and the memories of struggling with family members. This is a picture that we were using a lot during the pandemic to try and get more support for treatment, oxygens to COVID patients in the Southern Hemisphere. The person in the picture is not dead, they're sleeping. It's a picture from Peru in 2021, and they're lined up with many other families waiting to fill their oxygen tanks because the hospitals had run out or the hospitals were shut, or many families didn't want to go to the hospital, they were frightened. They cared for their family members at home, which meant they had to buy oxygen on the private market. And they would line up, take their empty cylinders and line up and sleep overnight waiting for oxygen. We saw these images play out across Latin America, move into South Asia and come to Africa. So we must never forget, and I think anybody working in global health needs to make a kind of personal pledge that if you're going to be working in this area, never again. This can never happen again. Post-COVID, because of what happened, there's been a major global health reckoning, and this is the crossroad. We're at a crossroads I mentioned to you before, with some really painful questions. Why did global health perform so poorly during COVID? Why did so many people die unnecessarily? Why did so many people in the Southern Hemisphere wait so long for protective equipment, vaccine, and oxygen? Why did some of the worst affected regions wait so long and often receive nothing? Latin America is a good example from global health. Why did global health decision makers in Geneva, New York, Seattle, and London, because that's where they're located, have so much power? Were populations more vulnerable to COVID because global health had neglected NCDs? There's this theory that the reason the death rate was so high in some parts of the world was because of the underlying chronic conditions. You put a respiratory infection on top of a chronic condition like diabetes, hypertension, and the risk of death is so much greater. But global health had been paying no attention to NCDs. And the big one, which you'll have to answer in your careers, has the entire global health enterprise been exposed, controlled by rich governments who will serve themselves at the first hint of crisis? And if so, how do we change that? So you're entering now an era where there's a window of opportunity, which is exciting for you as people in this field beginning your careers, where a whole lot of new ideas are coming up to try and change the future. USAID, one of the biggest funders in global health, is talking about localization. What they mean by that is actually transferring money directly to local groups. At the moment, most USAID funding is held by a large group of international NGOs and UN agencies before it can trickle down to truly local actors. USAID has put a flag in the ground saying we want to change that. Local manufacturing, super relevant for the work you do. Africa particularly, the African political and health leaders said we will no more be dependent on external supply chains for our basic health goods. We want to manufacture more on the continent. Gavi has responded, putting $1 billion recently into an Africa vaccine manufacturing accelerator. Expect to see more of this kind of investment in local manufacturing, including of medical devices, all the things that you're working on. New national public health institutions have popped up, once again, largely African, the African Medicines Agency, the Public Health Foundation, and more. This is once again Africa saying we want to invest in our own continental institutions and have those funded rather than have money come through international organizations who at the end of the day answer to their donors, not to African governments or the African people. Pandemic treaty currently being negotiated right now by the World Health Organization, hugely controversial. Pandemic fund, the World Bank has $1 billion fund available so countries can invest more in pandemic preparedness, including in new medical devices. There's a new Global Oxygen Alliance. And the last one I had to put on because very excited about this, and it's something I'm working on, regional centers of biomedical engineering excellence, to really invest in the profession of biomedical engineers. So what does all this mean for you? There's a big opportunity. This is a great time to be biomedical engineers in global health. Because of the past and concerns with what happened during COVID, there's an appetite for new devices, new thinking, new leadership. So the article on the left was written during COVID. It's called Engineers are the Unsung Heroes of Global Health in Forbes. It's a beautiful piece. You should read it. It includes the voices of many biomeds from all over the world and really celebrates the work that they were able to do during COVID. You know, many people survived during COVID because there happened to be an engineer handy who knew how to work with an oxygen cylinder, or who knew how to fix a pulse oximeter or work on a ventilator. If that the clinicians, many of them didn't know how to work with the machines. So I think there's an appreciation of the profession. And there's groups mobilizing. You'll see someone here who's in the audience, the fantastic June Madete. June, welcome, from Kenyatta University in Kenya, a major force for biomedical engineering on the continent. And June had joined force with some of her other women in the profession to build the African Women in Biomedical Engineering Alliance. This is a new professional association which is mobilizing women. Millicent Alou is underneath in the red. And then Deba Loyo at the top from Uganda. So there's fantastic people really wanting to mobilize to strengthen the profession. So I thought I'd go out on a limb for the remaining minutes and really put a proposition to you, which I would love you to push back on, argue with, debate, to help you prepare for impact if you choose to go, and I hope you do, become biomedical engineers working in global health. It's a prescription for global health progress, given the environment we're currently in. What we really need are professionals who can engineer the most cost-effective solutions, cost-effective, critical in global health, to the leading causes of early death. I'm going to make an argument that you should be working on technologies that disproportionately benefit people under 50. Controversial, but I'm going to make the argument. With, not for, with the largest, most vulnerable populations. Make your machines do your work in the populations that are going to benefit from it. And you have to engineer their uptake. It isn't enough to make a device. You have to get involved in the use of it and increasing uptake, which is much harder than building the device. So to deliver on that as young biomedical engineers, you need to know certain things. You need to have certain information in your heads, data. So I'm defining early death as under 50, but you can draw that line. There's debate about where that line should be drawn. That picture is all causes of death for all ages. So to the right of the red line are the older folk, to the left are the under 50s. And you can see straight away, children, the burden of death amongst children, all the bars to the far left. Children are bearing the brunt of deaths amongst the under 50s. What are the leading causes? What an interesting list. This is the leading causes of early death for everyone under 50 in the world. Neonatal, we know that this is a major cause. So anybody working on anything to do with neonatal, any engineer working on is really working in a high impact area. But there are others: pneumonia, road injuries, diarrhea, AIDS, heart disease, malaria, congenital defects is huge and understudied. Self-harm is there, and tuberculosis. What a mixed bag of conditions where we need good engineering talent and solutions. You have to know the most vulnerable age groups. We've talked about babies a lot, neonates, but children as well, older children. And when we come to working age adults, look at this. We don't talk about this enough. There's gender inequality, but it isn't women, it's men. Many more young men die under the age of 50 than women. And that's largely due to additional male deaths from road injuries and heart disease. So if there's an argument here for a focus on gender amongst 15 to 49-year-olds, we've got to help these young men. So really important to understand the sex differences. This is the top 10 causes of death for men and women aged 15 to 49. They're different lists. So you can see the men, cirrhosis and violence, pneumonia are on the male list. Women, we look at maternal mortality, that's childbirth, but the cancers as well, breast and cervical. So be very sensitive to these sex differences when you're engineering solutions, and you may want to work in fields that disproportionately benefit women, but I would just put my hand up for the men. Not enough work going into engineering solutions targeting their leading causes of early death. You need to know the high burden regions. You need to know where you work matters in terms of impact. So the far left is neonatal deaths by region. The two bars to the left, it's an African and sub-Saharan African and South Asian challenge. If you're not working there, I would argue you're not having your highest impact. Children, this is very interesting. It's really sub-Saharan Africa, your older children, where the mortality is. And if you want to focus your work on adults of working age, it's much broader. You can work in a much broader list of geographies. But it's interesting how the challenge for neonates and children is really concentrating in Africa in the future. And the high burden countries. So we keep coming down by geography. So these are the top 10 high burden countries when it comes to early death. And look at this list. USA is on it. Ethiopia, Russia, Pakistan, China. It's a mix of high, middle, and low income countries. So global health is truly global when you work with this framing. It's as legitimate to be working on a subpopulation in the US with high mortality as it is in the DRC, if that's the right population in terms of what's killing them. So it's not enough to just look at the direct causes of death. There are risk factors underlying death as well. And it's very important as engineers, we have solutions in these areas as well. So that's the top 10 risk factors for early death. You can see them all. It's a real mixed bag, but any medical technologies that target these are also going to be hugely life-saving. And it's a really interesting list. It's not enough to know about direct risks now. As engineers, you need to be predicting the future. What is the future likely to cause? This is estimates from a group called Ginkgo Bioworks of the risk of another pandemic. And it blew my mind when I read this. This is hot off the press. In the next 25 years, where will you all be in the next 25 years? Imagine your careers, probably at the pinnacle. There's a 66% probability of another respiratory pandemic that will kill 10 million more people. So in your careers, you should expect one and prepare for one. And as biomedical engineers, you will be called upon to respond to that pandemic. So you need to prepare for that. There are also estimates in this report, which I cited, of where that pandemic is most likely to emerge. It is most likely to emerge in Asia, but then spread as COVID did throughout the world. And they looked at all different pathogens, not just respiratory, and they came up with respiratory as our highest risk pathogen. So with all of this data, you can zero in as biomedical engineers on the engineering challenges that can save the most lives. Okay, what are they? I'm listing some to, I hope, inspire your appetite. And I'm calling them wicked challenges. And I just want to define that so we're all clear on what I mean by that. A wicked problem is a problem with many interdependent factors, making them seem impossible to solve because the factors are often incomplete, in flux, difficult to define. Solving wicked problems requires a deep understanding of the stakeholders involved and breakthrough approaches. But the return of engineering solutions in these areas is potentially massively life-saving. So I'm not going to go through all of those line by line. I'm sure you'll have a copy of this deck. But as engineers, this is where we don't have technologies and we need them. And the data tells us you would save huge numbers of lives by focusing in these areas. So I'll just call out maybe a couple. Low birth weight and preterm birth, massive risk factors. We don't know how to prevent them. So any technology that helps get a handle on preventing that is going to be hugely beneficial. Congenital defects, it's a huge cause of death and disability. Global health does really very little about it. So if you're interested in a greenfield site where you can really be pioneering breakthrough technologies, congenital defects would be one I would single out. The third one you might push back and say, what does a biomedical engineer have to do with nutrition? Well, we've left nutrition to the nutritionists for decades, and it's the one area which just has not progressed fast enough. So I think there's appetite now. Let's go to the engineers and see if they can help. I pulled out breast milk and nutritional supplements to prevent wasting, but any kind of technologies that improve the identification of malnourished babies or adults and corrective solutions. What can technology do? At the moment, we just really have very simple tools and nutritional supplements. There have to be better solutions here. Early diagnosis of pneumonia. Anybody that comes up with a way to distinguish bacterial from viral causes of infection is going to win a Nobel Prize, because this will enable us to get a handle on antimicrobial resistance and actually control the prescription of antibiotics. So that's a big one. Critical care needs in low resource settings are huge. ICUs, anybody that's retooling all that very expensive critical care machinery you will see here for low resource settings is going to be in a high impact area. And maybe I will just call out the last one, number 10, new generation of pandemic and climate change proof medical devices. Our medical devices are not built to withstand or respond to pandemics or disasters. So that's a huge future area as well. And it's not just about the technology being more robust. It's also about distributed manufacturing of medical technologies. One of the problems with COVID is, particularly in the Southern Hemisphere, the devices were all coming from the north or from China. They had to cross long seas, they had to sit in ports. It took forever. And so now there's an appetite, and I'm glad Rob Reed is here from Public Invention, because their team is working on distributed open source manufacturing of medical devices. So when disaster strikes, you have teams distributed regionally who can mobilize with biomedical engineers and make what's needed quickly and get it out to the hospitals. This is a huge area where we need more biomedical engineering talent. And if you're interested, I'm sure, Rob, you'd love to speak to some of the students here. Never forget this. So part of the prescription for progress was you have to engineer uptake as well as engineering devices. And we often forget when we're thinking about how a device should take off and be used. We think about clinicians. We think about community health workers. We don't think about women of reproductive age, mothers with children. And this evidence always knocks me out. So fully half of the reduction in child death since 1970 has been due to increases in the education of women of reproductive age. When you educate a mother, you transform the health of the child, the family, and the community. So as biomedical engineers, you may not think you have any connection at all to literacy and education of women of reproductive. You do. Make this part of your practice. When you're designing technologies, think about the mothers of the patients, or the mothers as patients and as family custodians of health, which is still the case in many settings. So I want to conclude just a little personal comment. We're all on a journey. That's what life is. We have many of you who've come from long distances to be here. Many are dialing in from far away. So life is a journey. Your careers are just beginning. You'll look back in 20, 30, 40 years, and I promise you, you'll never have been able to imagine what you've been able to achieve and the places you've visited and the things you've done. On the left is where I grew up, in Western Queensland, Australia. It's a very small town, 400 people when I lived there in the 1970s. I think it's less now. Fast forward now, and I live in New York City, so those two are worlds apart. And I'm sure many of you will have similar career trajectories where you'll end up very, very far from where you came from, but it always is always inside and with you. And I thought, if there's one thing I could share with you, all the places that I've been, the people I've worked with in global health, what would one message be for you as these incredibly educated, committed young biomedical engineers just ready to launch yourselves into a world that desperately needs new solutions, new leadership? It would be this: Our greatest hope for world progress in the 21st century may well rest on one factor: younger generations finding ways to cooperate beyond nation, religion, race, and gender on a grand scale. We're doing that today. It's a microcosm of that grand vision, but I truly believe with our interconnected world, if we can find ways of working like this, the future of our species, of humanity, it will be brighter for all of us. Thank you so much for the opportunity to speak with you.
I think we have a little bit of time to open up the floor for any questions that we might have for Leith.
It's always the first one that's the toughest, right?
Thank you, Leith. You unfortunately, talked about a lot of death and unfortunate things, but I wonder if, in your experience, this global health as a community that you described is in fact the high point of human cooperation to solve a major problem, even though it's insufficient to the problems that we're having right now.
So I love that, Rob. I mean, as human beings, our primary motivation is life, is the survival instinct, is to live. And our long lifespan, we're lengthening our lifespans all the time, is seen to be the greatest human achievement. So I agree with you. Global health sets a kind of, if we can't cooperate on the basis of all of us living, what else can we cooperate on? So I do think it's foundational. And I like the way you say that, because it means what we do here in global health can set a standard, a model of cooperation beyond all those differences I just spoke. I don't think we're there yet. I think COVID really punctured people's faith and led to a lot of second guessing. What I hope we don't walk away from global health as a result. I hope we don't say it's nation states, it's everyone for themselves. That's the way the world works. We just have to live with it. I hope we come back and rebuild our international institutions. The United Nations is not fit for purpose. It was built after the Second World War. It needs to be rebuilt. The pandemic treaty is one effort to try and come up with a truly global instrument that can curb the powers of rich nation states during a crisis, but it's very, very contentious. But all of this will be up to you to do. It's going to be your world to build those global instruments. And I'm looking out on this audience, this sea of faces from so many different parts of the world. It has to be possible if you people are in power. It has to be, because you carry with you a global perspective. So I'm optimistic when I look out in an audience like this, but unfortunately, you're not leaders yet. You just have to stay with it, and you're not, I guess, stay with global cooperation and really hone those skills, because people who can function in that kind of environment, they're very precious global resources in our current world, which is so at risk.
Thank you for a really wonderful and inspiring talk. One of the things that you mentioned was that engineers need to think not only about developing technologies, but also moving toward implementation of those technologies. And I wonder if you have advice for the students in the room. Their education has focused on teaching them how to be good engineers, and not so much on teaching them how to think about implementation. What advice would you have for people at this stage of their career to learn more about how to do that well?
Yeah, oh, this is such a big issue, because you hear all the time a great technology is created. We have so many stories like this. And the biomedical engineering talent is so strong, and everyone's brilliant. This is a great device. It's never used. It's never used. And I was speaking last week to a neonatal nurse in one of the Ethiopian hospitals, and he was really frustrated by this, that there wasn't enough education around the biomedical education to teach people how to use things. It was sort of left to the clinical staff. I would love to see biomedical engineers take classes in demand generation, and there's a whole field of communications as well. If you can combine that with your engineering, so you know how to take a device that's ready to go and generate demand for it. And sometimes that feels like generating demand, you're selling a product. I'm not talking about a commercial kind of thing. In global health, we talk about it differently, but it's really educating the people who will use the device, how to use it, what it is, being involved with advocacy communications people, the look of the device, the way you talk about the device, all these are skills that you should really have. If you don't have them, work in teams that have them. Make a conscious effort to partner with communications experts and demand side experts. This is something the commercial industry has down pat. So the Pfizers and the GSKs of this world, when they come up with a new drug, they know exactly how to engineer its uptake. But on the medtech side, where the global health medtech side, we're weak in this area. So that's a great way to distinguish yourself, Rebecca, as an up and coming biomed. Either develop these skills yourself or partner with people who have them in a team. There was someone over here.
We have someone
actually-
online.
Yeah, we have an online question. Can you share any positive stories of hope that you've witnessed with diverse people collaborating? What can we teach our students to instill these skill sets?
So I would talk about the Every Breath Counts Coalition, which is a coalition that I lead. The title is coordinator, which just means I try and keep everyone connected. It's an open access coalition. We accept anyone. And as a result of that, we have more than 100 members, ranging from individuals who are committed right through to the Gates Foundation and governments. And we try and put all these people together to mobilize support. So we were the group that, when we saw all these oxygen disasters playing out during COVID, and we were getting calls every week, my father's dying, or hospitals saying we have no oxygen, we mobilized our coalition. We were meeting every week for 90 minutes to mobilize support and to really advocate and screen for action. Very, very diverse group, but we were very united. If you have a shared vision, anything's possible. So the shared vision was keeping people alive, to Rob's point. There's nothing more motivating and uniting than that. And we were it took us a while, but we managed to get $1 billion in oxygen support through the international COVID response out to more than 100 countries. And that was we had no special funding to do that. It was simply the power of people, passionate people, coming together every week with a shared mission, which was to stop these unnecessary deaths from happening. So I would definitely encourage you not to stick too much to you'll work for institutions, they'll pay your salary, but don't stick too much in the institution that's paying your salary. If you can really think of yourself as borderless when it comes to who you work with and for, and just surround yourselves with the people and the organizations that have impact. We love breaking down barriers between institutions and just working with committed individuals. I think it can be hugely impactful. And there was a second part to that.
How can we teach our students to instill these skill sets?
Well, practice. There's nothing like practice. I mean, you've been working in teams. We're going to see the fruits of your labor soon. So teamwork can be tough, but there's no other way. There's no other way to get a complex job done than to work in teams. So, but I like working in like super epic teams, like 4 or 5 people. Every breath counts. Some of the calls we had like 150 people on calls. It was lockdown, so we couldn't meet face to face. And just organizing that many people is a challenge, but oh my goodness, there's just something powerful about human cooperation at a grand scale. When everyone's working and when all our brains are working to solve a problem together, there's this energy and feeling that anything's possible. If we can put some of our differences to the side, and we do have to do that. So practice, put yourself in teams, big teams, search out opportunities where you can work with large groups of people.
Hello.
I'm sorry, excuse me. There's a woman here who's had her hand
Oh,
up.
excuse me. I'm sorry.
That's okay. Could I take that and then you? Thanks. Thank you.
Hi, thank you so much for your talk. My question is, as students and young engineers, how do you propose we can begin making a real global impact, especially in a world, like you said, that is still controlled by larger corporations and rich government? Like, how do we, what would you say are the first few steps in starting our journey in this world?
Well, hopefully you seriously consider a career in global health as engineers, biomedical engineers, which means you have to be very selective about who you work. You have to be very, very conscious about who you work with and for. So there are organizations that are better than others in terms of wanting to challenge the status quo. So I would, and this of course is a great, and competitions, doing this sort of work is great, aligning yourself with top universities like this one, the work that you're doing. So that's all important. But when it comes time to get internships or jobs, I would be very selective about working for an organization with a leader and leadership that wants to challenge the status quo. Some of those items I listed, the localization and other things, there are institutions behind those. So check out the leadership. There are still a lot of very, very, like yesterday's leaders running a lot of international institutions, but there's new people coming through all the time. So I always advise people, check out the CEO, look at the board, look at the leadership, look at their public statements, and don't necessarily go for the brand names, the names we all know that work in global health. Don't necessarily go there. But a lot of these new African institutions that are popping up, looking for top talent. I mean, go to some of the new kids on the block, and put your expertise there. Yeah.
These two here.
Yeah, thank you so much for your presentation. In terms of bioengineering, I tend to think of that sector sort of in two components, where you have that mechanical side and the devices side, and then you have the materials and chemical side. And I see an affordability with the mechanical side more in terms of devices for global health outcomes. But with the chemical side, it seems to be exaggerated in terms of pricing. So how do you see the pipeline or like the timeline for sort of that chemical bioengineering projects reaching those global health solutions or outcomes?
So can you give an example?
Yeah, so I tend to think of maybe drug discovery or tissue engineering, for example, seem more on the material and chemical side, and they tend to be very expensive and difficult to manufacture, especially maybe in developing countries. The resources might be not available to maybe manufacture a tissue sample or something. So I was wondering, how may we try to go about that? Yeah.
Well, I'm more optimistic. I think there's a lot of discovery happening, and a lot of discovery will happen because of all these institutions that are being built, particularly. I keep singling out Africa only because there's so much leadership coming out of the continent to change the status quo, but there's plenty going on in South Asia, Latin America, the Middle East, plenty of innovation. But a lot of the materials and other products are so expensive because they're here, they're made here or in Europe. So re-engineering, coming up with different local solutions, it's going to reduce costs. So if you're really interested in that, I would get involved in some of the work that's being done on the continent, African continent, or in some of the other countries where they're trying to re-engineer materials using a lot of local products. And some of our colleagues in the room here would be much more, if you could just introduce yourself to everyone, actually, Ken, do you mind? So, because you may want to talk to each other. Just want everyone to know. Sorry to put you on the spot.
Okay, thank you very much. My name is Ken Iloka. Thank you. I'm Ken Iloka. I'm a biomedical engineer and a lecturer in Kenyatta University. Dr. Madete is my chair of the department, and we are very keen on what we are really discussing here, because we realize that we're in a different context, and the solution that you are coming up with really need to fit in the context. And with these innovations that are coming up, it's very, very clear. As at now, we have the GMI program, which is running here, and at the same time, working with Rice University to set up one in East Africa, and specifically Kenyatta University, whereby we really need to come up with this kind of solutions. So with this collaboration, there are opportunities which you can all really collaborate with us and with our students, and that way we'll get solutions. So we're really happy to be here.
Thank you. Thanks for that. And sorry again. So there's all these new initiatives that are popping up that are looking to really change the cost equation for med tech devices. But I don't think that innovation is going to come from high-income country. I mean, there's only so far you can go, and Rice has done a great job. Nest has done a great job trying to get the prices down. I think the next round of innovation is going to come from local teams working with local materials. Yeah.
We have time for one from this side, or
I can be really
Okay.
brief.
Thank you.
My question is just about how we see the impact of like global health organizations or the design goals, focusing on conflicts that are going around. Obviously, there's lots of conflicts happening. I'm thinking of a couple very specific ones, but people are dying due to excess deaths, malnutrition, lack of healthcare. I'm wondering how you see, maybe your work or other work impacting those communities.
So my own work focuses mainly on respiratory conditions, so pneumonias and other respiratory conditions. But I have worked now, but in the past I've worked on child malnutrition and a whole range of areas. But conflict settings, I'm glad you raised this because we don't have good models to work in these settings. Even the humanitarian actors that you would think of like UNICEF and some of the Red Cross, they're struggling to work in these settings. And when you look at what's happened to child deaths, and I think it's true for neonatal as well, they're concentrating each year. They get more and more concentrated in fragile and conflict affected areas where the governments don't function. So as biomedical engineers, I'm actually so happy you raised this. You have to be thinking about this. How would you as engineers work in these settings where there's very little lab capacity, there's very little government services, but the need is absolutely acute? Is it possible, I mean, even thinking out loud, is it possible that biomedical engineers could have mobile labs to function in these settings? But I agree with you. If we don't find better ways to work in these communities, they'll just fall further and further behind. And it is related to climate change as well. A lot of it is food driven. And the conflict comes after the food, the competition for scarce food resources. Yeah, but I'd love, do you have any ideas yourself for how? Yeah. And there was one more.
So first of all, thank you for the presentation. It was really great. My question is really just out of curiosity. You mentioned we had a lot of progress sort of like prior to COVID, especially in terms of like different like chronic illnesses. Do you think that, say, COVID had happened like 10, 15 years later, do you think the death toll would have been smaller had we continued sort of making progress in those areas before it happened? Or do you think regardless, just because like the pandemic was a big shock, like it would have had the same impact regardless?
Oh, that's a tough question. I think if we'd had more time to get a handle on chronic diseases, particularly in middle and high income populations, all the diabetes, the hypertension, the obesity, which is getting worse. All of those things are getting worse. If we'd had more time to get the populations in better health, particularly in the US, parts of South Asia, Latin America, and Europe, I do think the COVID death toll would have been less. I think a lot of people died because they had comorbidities. And yet I'm not positive about our ability to get those things under control. That's a huge challenge for the public health community, particularly here in the States, is how to get these risk factors under control. So I think it's our challenge now is to prepare populations so when the next pandemic does come, they're not as vulnerable to dying. I think that's a key challenge. And that's part of the mission. You will be some of the first generations of biomedical engineers working in a pandemic threat environment, constant pandemic threat environment. This is the world you'll work in. So this is your challenge.